Hello, everyone. I'm Stephen Toe, CEO of Leo Cancer Care, and it is my pleasure to welcome you all today to our symposium on online adaptive treatments in radiation therapy. Now, at Leo Cancer Care, we had a fantastic estro back in August, and it was really obvious just from the buzz and the conversations we were having with people there, that there is a real huge interest in online adaptive treatments now in the field. And I'm really excited and really delighted to have a fantastic group of speakers with us today that are going to be talking about this excitement in online adaptive. I've got Niek Schreuder, who is the Chief Scientific Officer for Leo Cancer Care. I have got Mackie, who is the co-founder and chairman of Leo Cancer Care. I've got Nikos Paragios, the CEO of Therapanacea, Uros Mitrovic, the director of marketing for Cosylab, and Fritz DeJongh, the CEO of ProtonVDA. So let's get started with this now and start by bringing it to you, Rock. Now, you've been in this industry for many years and really helped shaped the radiation therapy industry for a number of years. So really interested to hear from your perspective why you think there's so much buzz now around online adaptive and what we need to do as an industry to really bring this into clinical application. So I'll hand it over to you. Really interested to hear your thoughts on that. Sure.
Next slide. Yeah, I mean, really, the drivers today are that we are starting to have enough computing power to do all of the calculations that we need. We are starting to have the algorithms. We're starting to have the hardware that can do the imaging in real time and very specialized imaging. And if we go back a few years, I've spent most of my career really trying to do offline adaptive radiotherapy, and it's basically about imaging, planning, and QA. And then when you start a course of treatment, if you find the patient is deviating, then you have to do, essentially a replanning exercise, and then accumulate the dose that the patient has received. And online adaptive is just all of that really on steroids. So you need to then integrate to that outside loop and not for the next treatment or even a couple of days from then, but you need to do it in nearly real time. So online adaptive really stresses all of the capabilities that you have of having the right imaging hardware, having the right algorithms, and a fast enough dose computation. So next slide. If we go back to the ICRU 83 report on IMRT, then there's really a hierarchy of steps that you have in radiation therapy delivery. There's the pre-radiotherapy workup, where you do 3D imaging and determine how you're going to treat the patient. Then there's a preparation and a mobilization, and the delineation of volumes. Then the planning and the optimized planning. Then there's a loop about selecting different planning aims and trying to get then an optimized plan, and that really determines a prescription. Then the delivery that amounts to imaging and adjusting the setup, and then plan adaptation is when you have to go and replan. And finally, at the end, recording and reporting. So real-time adaptive is really focused on these areas. They're getting a new a GTV, CTV. And CTVs are really difficult because it really requires a physician today to determine what the CTV is, because by definition, you can't see the presence of a CTV. And so it will require artificial intelligence. The planning aims step, of course, needs to be done extremely fast. It would be maybe difficult today to do this with Monte Carlo, for example, then to adjust the setup and to adapt the plan. So if this is going to be done in a single session, then it really requires high-speed computation and very good and stable workflow. Next. course, we're going to be imaging more, and it requires really specialized planning images, but also image verification has to be done. So there should be a circle here as well for imaging more often, and different and specialized hardware to do that. Next. And then optimization. And, I think we need to start thinking about how we set up the patient, how we immobilize the patient. Is supine and prone the only ways that we prepare the patient for treatment? And we think that upright, either in the seated position or in a semi-standing position, perch position, is maybe optimal sometimes. And then, of course, being able to image and set up the patient as quickly as possible is important. Next. And then finally, AI. AI is going to drive most of these boxes, especially in the pre-therapy workup. What treatments actually are working? If we could then find cohorts of patients, if we then could mine the prescription and technical data, and of course go and mine the reporting for complications. So really, online really requires real-time adaptive imaging more, optimizing, and artificial intelligence. Next slide. So the challenges really are algorithm development, high-speed computing, and hardware to really optimize how the patient should be treated and imaged at the time of treatment. So with that, I will pass it on to Niek Schreuder, who will talk about the hardware of Leo Cancer Care. And of course, Niek is a guru in proton imaging, having spent his whole career really in proton radiation therapy. Take it away, Niek.
Great. Thank you, Rock, for the introduction and the opportunity, and Sophie for organizing this. So what you see on this slide here is the Leo apparatus that we are bringing to the field of radiation therapy right now. And this will enable us to do the patient treatments and imaging in an upright position. Right in the center of the picture, we can see the patient positioner that can morph into a seated position, leaning forward or backwards, and also the patient in a semi-standing position. But key to this picture is the CT imaging ring. We have a dual energy CT ring that comes down around the patient and will scan the patient pretty much at the isocentric position. Of course, if the tumor is off the center of the patient, we'll have to shift the patient after imaging just slightly, but pretty much this imaging is right at isocenter. And the first point I want to make, I want to share four thoughts here with you. The first point I want to make is that now we get dual energy CT imaging of the patient in the treatment position or very close to the treatment position on a daily basis. That gives us the information we need to do adaptation. It gives us directly. So I want to emphasize the method of direct information here. If we use, for example, cone beam CT or any other forms of image guidance, then we first have to calculate from that maybe a synthetic CT, and then the synthetic CT need to be matched with a treatment planning CT. And of course, we all know our gold standard is the single energy or dual energy treatment planning CT. So we get here with this method a direct measurement of the patient's anatomy, all the parameters, and then we can on that we can apply the AI methods to really just check if the tumor and everything is right. But what I'm trying to say here is we are cutting out a bunch of indirect steps and go directly to the imaging information. The second important point is if the patient is upright, the patient rotates and the beam is stationary, that means your imaging devices are going to be stationary. So that will lead us to much more precise and reproducible imaging. Another feature of this system is that we're rotating the patient around a rotating platform that sits on a massive bearing at the bottom, and that will give us extreme isocentricity. That the days that we make a move on the patient to rotate to the next beam and not sure where we really are at the right place, that will not be the case here because we do a very precise rotation. And the fourth point I want to make here is look at all the space around the patient. Suddenly the patient is not in a tunnel anymore and the patient is exposed. And this is true for X-rays as well. If we want to put a patient this device in front of an X-ray beam like our Ruby product, then we have much more space to do image guidance. And one of the things we can do in the proton therapy space is proton radiography. We can see we have plenty of space next to the patient to bring the radiography panels in, which you can show in the background. But then leads me to introducing Fritz DeJongh. He's the CEO of ProtonVDA. And they developed proton radiography a couple of years ago. The system is in prototype for a couple of years. And Fritz will walk us through how the system works and the benefits of bringing that to the ISO center in a proton therapy upright solution that will then allow us to verify the real-time adaptation of our plans. Fritz, over to you. Fritz, you just need to unmute.
You're on mute, Fritz. You're on mute.
Okay, sorry about that. Okay, thanks for the introduction. And let me start with this slide, which shows one example of a publication which looked at the benefits of online adaptation. So in this case, if you can detect anatomical changes such as sinus cavities filling or emptying and adapt to the current situation of the day, you can use much more narrow fields like the ones on the right and get more conformal treatments. So you can use plans that wouldn't be robust under current uncertainties. So let's go to the next slide. So we've been funded by National Cancer Institute to develop proton imaging, which is one way to use a beam's eye view to detect anatomical changes as well as other range uncertainties in general. We've also partnered with Cosylab now for the clinical development. So the photo shows our system in operation at Northwestern. We've used the system to demonstrate proton radiography as well as proton CT. This system measures individual protons to reconstruct the image, and it's designed to use pencil beams. So we can image and treat with the same system. A pig's head is shown here and ready to be imaged. So the following slides will show real data for this pig's head, both real X-ray CTs, real proton CT, and a real proton radiograph, which is shown here on the left. So proton radiography brings the prospect of an efficient online alignment as well as a range verification with the patient in the treatment position. And the basic idea for using PRAD is to compare it with a digitally reconstructed radiograph derived from the 3D planning map of relative stopping power that was used to find the treatment plan. So this DRR can be used to check the alignment of the patients, which is based on the overall features and patterns of the image, and anything left over can then be a range uncertainty or maybe an anatomical change. So we have some examples of this in the next few slides. So let's move to the next one. So on the left is now shown a DRR from the X-ray CT. So it looks very, very close to the PRAD. And on the right, we have a difference image. So subtraction of the X-ray digitally reconstructed radiograph from our proton radiograph. And we can see the effect of just a 0.3 millimeter vertical translation. So it's easily seen as a discrepancy in the difference map here. And we have more examples. Well, also in this image, you can see there are actually range uncertainties in the region of the sinus and range uncertainties in the region of the ear bullae that don't completely cancel out no matter how well you do the alignment. So the next slide shows we can also detect rotations, in this case an in-plane rotation. Let's see the next slide. And so this slide actually shows an out-of-plane rotation, which is detectable as well. And one more slide. Oops, back one. Yeah, so now on the left, instead of an X-ray digitally reconstructed radiograph, this is a digitally reconstructed radiograph from our proton CT on the left. And now when we do the difference image on the right and we align it as well as we can, we see actually very good agreement in the difference map everywhere. So here's an example of very low range uncertainties. All right, go to my last slide. So one question is, can you use these proton radiographs to update the map of relative stopping power that's used for treatment planning? So if you see a discrepancy, can you use one PRAD or maybe several PRADs or more general proton imaging data to do this update? There's quite a few publications on this, so this is work in progress. And with that, I'll introduce the next speaker, Nikos Paragios, who's a distinguished professor as well as an entrepreneur now at Therapanacea, an expert on artificial intelligence who will talk more about how we can use all this data to rapidly adapt these plans online. So thank you.
Thank you, Fritz, for the introduction. As is mentioned before, Therapanacea is a software development company that is developing a full AI-based treatment planning solution for radiation therapy with a focus on the adaptive. If we look on what is happening during the past 2 decades in radiation therapy, we can observe that there is a huge progress that is done on the hardware side, especially for initial planning. But what is lacking is software that is able actually to exploit the latest advances of hardware, in particular when we take into account the development of advanced solutions for imaging as the one proposed in Lyon Cancer Care. If we look on the limitations of an existing workflow for treatment planning radiation therapy, we can say that it heavily relies on human expertise. At the same time, it also introduces a significant amount of actually unequal access to treatment, because the quality of the treatment that the patients will be getting heavily depends on the. Most importantly, what I will say today, because of the lack of adaptive and online treatment adaptation, we do not take into account anatomical changes that are essential. And these anatomical changes, in order to address them, we introduce a significant margin in terms of tumor and target delineation, which heavily increase the toxicity. We can even go more farther and say today that most of the existing solutions, because they rely actually on human expertise, cannot be used in developing countries where the expertise is lacking. If we want to summarize the state of the art today in software asset-conscious treatment planning, we could say that it heavily depends on humans. Therefore, it cannot be used for online adaptive, simply because we don't have sufficient amount of time to complete the job. That's the first statement. The second statement is that because of the fact that we do not do online adaptive, most of the treatments are associated with high toxicity, and the fact that actually we introduce additional margin. And therefore, we have as a counter effect the development and of lifelong side effects, which are important for the patient. What we develop in Therapanacea are software solutions that are AI-based, that actually can help us to address these limitations. So what you are seeing on the video on the left upper hand side is our automatic delineation product that today is CE and FDA marked, and actually is treating 1 out of 5 patients in France, both for MR and CT. We're able to automatically annotate within some dozen of seconds more than 150 structures in the brain. And what you are seeing on the lower part of the video actually is our automatic synthetic CT generation software that is able within a few seconds to generate a fully planning compatible CT from MR images, T1, T2, or even low quality sequence as the one of 0.35 Tesla of true FISP. Can we go for the next slide, please? If we look on our ambition is actually to revolutionize radiotherapy by looking mostly on contributing on the adaptive personalization of treatment. We have already developed tools that actually allow us to address the low-level task of radiation oncology, like automatic annotation, like real-time fusion, like the ability to do the same thing on MR images. What we're delivering next year is the first AI-based treatment planning solution that should be able to determine automatically the constraints that can be used for the patient given the localization of the tumor and the prescription of the physician. And our ambition is, in conjunction with the deployment of novel hardware solutions that allow online adaptation, as the one introduced by Lyon Cancer Care, is to offer a holistic software-based solution that is able within a reasonable amount of time, which can be dozens of seconds or less than a minute, to do the whole adaptation process, including annotation, target delineation, association with the initial CT planning, as well as re-estimation of the optimal plan. And in the longer run, what we would like to do is to go beyond the principle of one tumor, one dose, and look on local characterization of tumor aggressiveness and be able to adjust the prescription on this basis. After this short presentation, I would like to pass the speech to Uros Mitrovic for Cosylab. One of the main issues today when you are talking about convergence of software and hardware is their efficient integration, and Cosylab should be able to give some thoughts on how this can happen effectively.
Thank you, Nikos, for the introduction.
So please, the next slide. So as mentioned before, the goal of having adaptation while the patient is on the table, the key is in the software, as also Nikos emphasized. But here, I will talk about software in a little bit different aspects and perspective. In a standard setup, you have a patient which comes to the treatment room, it's verified, you have a patient setup on the couch, you're doing imaging, you verify that it's the correct position, and then you're doing the treatment. But if you look the machine like LIOS we have here, as Niek explained, where you have an imaging in an ISO center, what is very important and what was crucial in design of a treatment control system here, that it has to support all these different in-room imaging modalities, in this case, dual energy CT or proton imaging, and also to allow fast data transfer to and from treatment machine. So next slide, please. Can you have next slide? Okay, great. If we look into the interface between the machine, the treatment control system, and the online adaptive software, so on one hand, the treatment control system has to send the in-room images like dual energy CT, proton imaging, CBCT, or whatsoever the treatment device has. And then the online adaptive, as Nico said, is doing some processing, assessing the anatomy change, and replanning if needed. Once this process is completed, the adaptive plan is sent back to the treatment control system. And then the workflow continues in the regular manner. So what is here really important, that the treatment control system has to be designed in such a way that it supports the work with original, but as well as adaptive treatment plans. And now I think we can go to the next topic and have a more discussion.
So thank you very much, guys. That was a really good summary of the different elements that have got to come together to bring online adaptation into clinical utilization today. And I think that in summary, what you're really getting across here is that it's not just hardware or just software. To bring this to reality, all of those bits have got to come together, right? You've got to have high quality imaging, things like dual energy CT, proton radiography. We've not talked about MR here, but that's also obviously a very interesting topic within the industry. But it's about bringing high quality imaging to the ISO center to collect high quality data. And once you've got that high quality data, it's then about saying, well, how can we utilize this? How can we bring in the AI algorithms? How can we bring in the software platforms to make use of that high quality data, to do the plan adaptation, to deliver higher quality and better treatments to our patients? That's what we're all trying to get to. And we believe, at Leo Cancer Care, certainly when we founded this company, that upright patient positioning with fixed beams is one way, exactly as Niek said here, to bring that high quality imaging to the ISO center, to enable new novel imaging modalities to be poured into the treatment room. And that's something that we're very passionate about here. So we talked about the hardware and we talked about the software coming together here. The thing that we've not really talked about a great deal is the regulation that sits around this and the quality assurance. And if we've modified this treatment plan, we've adapted the plan, how do we quality assure that? How do we gain that confidence in that treatment planning capability? So, Rock, I want to throw that one back to you and just see your thoughts on the regulations and around the quality assurance with online adaptive. What do you think about that?
And I'd just like to remind the audience, if they have questions, please enter their questions, and we'll do our best to answer them. So yeah, it starts with the data. So it starts with imaging data. It starts with the patient data, the plan data, prescription data, and the data has to be mined. The data has first of all, the data has to be curated so it can be mined. And I think clearly what we need to do is start reusing the data from prior patients. So whatever one does, it really requires having the data sets that have been fully curated by offline adaptation. I mean, how are people then spending their, Nikos said there was 4 to 6 hours typical planning exercise, human hours in the planning process. How is that then well enough documented, curated so that it can be used a convolutional neural network, for example, to sort out what should be done with the data? And then the regulation has to then accept AI-based planning without too much without too much emphasis on whether or not it's automated or fully automated. So I think it's going to be a very long time before it's absolutely fully automated class 3, but we do have therapists that are monitoring it. We probably need to make sure that the therapists understand the processes well enough, that the training of how to use AI in online adaptive and even going towards real-time adaptive is how do we really interface with those staff members. And then of course physicists are doing the QA today, and if we're changing the plan, can AI really do the same job as a physicist? So physicists have to start really making sure that their QA is curated well enough. So it's going to take a whole family here of companies to do all of this process, and the integration has to be such that it can be done in a very safe manner.
Absolutely. And we just had a question come through, Rob, but before getting on to that one, I just want to really hand that question that you've left open there around the AI dealing with the QA, because I think it's a really important question to ask, and hand that one over to you for a second, Nikos, just to give your thoughts on dealing with the QA elements here when we're talking about AI in online adaptive. And then we'll come on to that question that we just had through.
Sure. I think one of the main advantages of radiation therapy compared to most of the other domains in medicine is that we have a huge amount of curated data. That means today in every hospital, because of the history of the patient and because most of the patients, they have a high probability of doing a relapse, we have an amazing amount of data, including annotations, including treatment planning, including dose files, including imaging. And this is one of the very few domains where actually the amount of data that is available exceeds beyond any expectation we can imagine with respect to developing these AI solutions. And when we look on actually the difference between online and initial planning, the main constraint actually is time. It means that we do not expect that the planning procedure in terms of result will be different. So the fact that we have this huge amount of data available actually give us the opportunity to consider algorithms that at some point should be able to do this, to have the same behavior as humans with rather similar precision. And these solutions, they can be implemented in an online setting. What is more problematic today, but I think this is also something that is changing in the artificial intelligence community, is that most of these AI solutions today, they do not have an efficient way of understanding when they are failing. But today we have more and more methods that actually try to impose causality, try to impose anatomical consistency on the decisions. So when we take into account the fact that there is a huge amount of available data on any aspect related with radiation planning, and at the same time, artificial intelligence is moving with more advanced architectures like generative neural networks, we can imagine that we are not that far from having algorithms that are as efficient as humans, and at the same time, they also have the ability to indicate when there is uncertainty with respect to the solution that they are deriving. And this is going to be an essential tool to actually implement a QA strategy that is more than necessary for the online adaptive.
Completely agree. Yeah, I think that's a really important point. And back, Rob, to the first point. The first point that you made, Rob, about collecting the data and the importance of the data in driving this. Somebody's come through here and asked what the main advantage of proton imaging, and that's really, what data do we collect from proton imaging? What's the benefit of it? So I'll hand that maybe to Niek or to Fritz. Do you want to address that? And please, do everybody get your questions in that we can address those.
I'll jump in real quick, and I think there's a lot of misconceptions here, but if I need to pick the main one, I think that initially the main one would be to help us really make sure our relative stopping powers are converted correctly. But that, I believe, actually, my experience tells me that we're actually pretty good on that. So as soon as we configure that, that's good. I think then the main advantage of PDAP will be detecting real-time anatomical changes like a filled sinus cavity or weight gain, weight loss in the patient's treatment area. But Fritz, you also spend a lot of time on this. So that's my clinical angle. And after analyzing all the data that's was developed by Mark Pankook and Fritz and the team in Chicago, I believe that's the two priorities.
You know, from the more fundamental physics level, you're directly measuring the proton stopping power, and then you have a chance to compare that with what you've assumed for the treatment planning. So if there's any discrepancies, it can feed into the clinical issues Niek just mentioned, and ultimately maybe, you know, be an input for this adaptive planning.
Yeah, I just want to add to that, that if you can have proton radiography and you're not going to work in all disease sites, but we don't need the immense precision and immense range sensitivity in all disease sites, but it will be useful for the disease sites where we need range precision, especially for head and neck, intracranial, and I think left side of breast. There we will be able to take a proton image even at the 230 MeV beam. And now we will be able to really remove range sensitivity completely. And if we can remove range sensitivity because we have a precise representation of Hounsfield number to stopping power, then we can start using protons as protons. So we can start treating with very small margins, and a lot of people is not thinking about that. But once we can start using protons as protons, and not protons as photons, and what I mean with that is that we adding such huge margins that the proton distribution look very similar to photon distribution in terms of conformality. It always looks better in terms of integral dose. There's many times that the integral dose doesn't really matter much, but precision and conformality matters. And I think that will really open up a new field. And once we can verify our adaptive plan by one simple radiograph, and we did not say that, but the dose from proton radiograph, Fritz can allude on that, is really an order up to 10 times less, up to 100 times less than an X-ray radiograph. So it becomes a workflow thing, but we can actually get tremendous amount of information from that.
Yeah, and I think just a follow-up question that we've had through there, Niek, on that is will we use the proton treatment beam for imaging, and how does that work? Yeah,
that's you would use the proton imaging angle if you can get through. Now, if you have a part of the patient that, let's say it's a left lateral beam you can't go through, then you can get the same information by rotating off the beam angle to get through the patient's body. But you're never going to use the proton treatment beam to image because you're not going to have the right energy. So you're going to use the same beam direction and the same isocenter, but you're going to use higher energy protons to go through the thickest part of the patient and lose low energy protons to map out the perimeter of the patient to see. And so typically, and Fritz again can allude on that, but we're planning to use about 3 energies to do an image, an imaging of the proton beam.
Yeah, I think, you know, the point is you're not using the treatment beam itself. You would do this before the treatment. You would use a higher energy beam because you would want to transmit through the patient, and you would use much lower intensity since we're trying to get that super low dose and measure 1 proton at a time. So basically, the idea is to use the same pencil beam scanning system and the same patient setup, but just a different actual beam delivery plan before you move on to the treatment delivery plan.
Yeah, absolutely. And I think the main point here is, as Rock pointed out right at the start, is around data collection. And the more information that we can get using the proton beam directly, the better our assumptions are going to be, and therefore the better our adaptation will be as well. So the higher quality data we collect, the better our modeling will be and the better results will be. I think that's the important piece. We've had another question here. Given current practice of developing a PTV and CTV that provide a margin to ensure coverage, is there any movement to reduce those margins within the adaptive planning model to increase the sparing of critical structures, or is that not part of this specific adaptive initiative? So maybe Rock, I know
so there is a
lot about the
movement
CTV.
to so there is a movement to get rid of the PTV, for example, and to do probabilistic based planning with real information about how the patient is likely to move, or how the patient is likely to not be corrected. Because if you can correct the patient, then you really should be applying a PTV on the basis of uncorrected, on the final uncertainty after correction. And I think there is an ICRU report that is working on really the elimination of the PTV. And of course, it was the ICRU in report 50 that described the GTV, CTV, and PTV. And of course, the CTV has to be one in which even the margins that are taken into account motion of the patient and how any kind of motion management doesn't finally correct the ability. So that should be all available again, especially if we are doing dosimetry. If we're curating the cumulative data that all offline adaptation needs to do today, if we could use that data, then we could find out how much, if you like, the dose distribution needs to have a margin on the basis of uncorrectability or the ability to correct. Does that make sense?
Yeah, that makes, I think, perfect sense. And I think that CTV discussion is in my mind the really interesting one. Everything else is easier to deal with, but that's certainly where the complication comes in, and I think where our AI is so important as well. One other thing that we've not really touched on through this that I think is equally important is around streamlining this workflow. Online adaptation is great, and bringing in this high quality hardware and software to go with it is fantastic. Uros, I know I'll direct this one to you because I know you're particularly passionate about this, but what do you guys think is the way that we don't bring in too many additional steps that slow down the workflow? How can we keep this a streamlined, optimized workflow? What are your thoughts there, Uros?
So I would say here, and actually refer what Nikos already presented, basically that role of AI is here to streamline the workflow, so to minimize the user interaction. So what we observed that what is typically not very welcome in the clinic is to have more work, yeah. And by having let's say AI tools aid to do the adaptive process, I think we will need to have also AI tools or some other methods to do automated QA. In this respect, only with these two steps together being automatized, then we can actually introduce no additional time into the patient workflow.
And I think that's the importance. For me, that's when I know that we've really achieved our goals. If we can bring this improvement, this plan adaptation into our workflow without it being detrimental to the number of patients that we can treat, then I think that's when we know we've really been successful here. And just
Stephen, I in the line of this discussion, I do see another question that came in about the plan approval process.
Yeah,
I assume you were going on to that, but let me just tie into that. And so I think the ideal scenario is, as we develop all this software, it's a no-brainer that the treatment planning system eventually will do the image guidance in the treatment room. So the ultimate software is your treatment planning system do the image guidance, and you can immediately, if the image guidance information comes in, the plan will just be automatically recalculated. Now, the very important thing in terms of plan approval, I'm going to say that to Ian here that asked that question, is that you actually have a very rigid set of boundary conditions that you have. This is my approved plan. And if my imparted energy, if my total number of monitor units, if my total size of the tumor or whatever you do change by a certain parameter, you would raise another flag. But most of the time, it's probably going to be within an acceptable parameter to allow you to treat that fraction. And then the QA becomes almost offline. And then you can go back and review what has actually happened and is there a trend? And we've been doing trend analysis for many, many years, but I see actually a flip over. You see, I could treat with this thing, with this current scenario, but I see a trend that I'll start drifting out. Or if I see a parameter that's too wide, far away, that could potentially now have a increased risk to the patient, adapting or not to adapt, I think you're just going to have such a lot of information. But what we have to remember is we have actually really a very strong benchmark, which is your existing plan. And you can set, I'm allowed to go 5% up in monitoring units, I can have 3% less in impartant energy and so forth.
I think those boundaries are really important, Niek. But, you know, as an industry, we've been through this before when we started imaging patients prior to treatment, and we brought in the ability to shift the table, for example. You know, we put boundaries around that, how much of a shift is acceptable, and it allows you to work within those boundaries effectively. So I think it's just, in my mind, building upon that and moving along in the same logic, exactly as you're saying. So we've got another couple of questions that have come through here. Another one related to this. So one solution might be working with some kind of change parameter limits from the nominal Niek, which I think is what we're talking about here. Anything else you want to just add on to that, Niek?
Yeah, so I think I just see Ian asked another follow-up question here. Is that's right? You know, you have to set a cadence of acceptable parameters that will allow you to come forward. But Stephen, can you please repeat that question again?
It was just basically you've already answered it around setting these limits to work within. But I think we've already touched on that, and I think that in my mind that is the future. That's the way that we will go, to be able to give you the freedom. And I think that plays into the last question on how you keep the workflow streamlined as well. It's definition of those boundaries and giving people those boundaries to work within, exactly as we do when we shift the table in current practice today. Another question, maybe I'll put this one to you, Rock, that we've had come in here about ideas to develop a super fast MRI for online imaging using
well, it's related to the last question, because we really know where the regions of interest that we really care about, right? We know that we have a GTV, CTV, PTV that we want to put in the right place in space, or is it the right shape in space? And so you can imagine, rather than just generating images that are maybe less interesting, you could focus more of the acquisition, and it's all about control of the gradients, right? So that the more you are, the three different directions of the gradients is really inquiring what's going on in some voxel inside the patient. So it would be perfectly possible to have preferential dwell time, so that you're gathering more noise, or you have less noise around the planning target volume, or what we'll call the CTV in the future, when we no longer need a planning target volume. And this would speed it up enormously, because the time it takes to collect an image is proportional to the volume that the gradients are surveying over.
Maybe I can add something here. I think the role of AI also can be something that can be a game changer, because today there is a sufficient amount of work showing that when you are training algorithms on the basis of limited resolution, limited acquisitions, while having available high resolution data, then you are able to reconstruct an excellent signal even when you go to a real setting scenario where you only acquire actually the low range signal. So I think the combination of what was suggested before, along with the ability to learn from high resolution data, the mapping between these two modalities, can allow you to have fast acquisitions of extreme quality in terms of characterization of target volume as well as the surrounding areas.
And just one question just before we wrap this up, and bring everything to a close here. The final question, again from Ian here, is to say, what if over time the CTV shrinks, as you're suggesting, Rock, and we depart further away from normal process today? Would we perhaps require new kinds of tools to address this kind of change?
Niek, are you going to answer this, or do you want me to answer this?
No, I think you should answer it. I already talked too much.
So do I, but yeah, no, of course, the CTV, there's two types of CTV. There's the occult CTV that really is nodes and so on, and then there's the CTV that is a margin around the GTV, and both of them are quite different, but both of them are such that we'll have to have imaging that can survey around the CTVs, whether it's around the GTV or a node, and that will really mean that we are surveying, and if it determines that the position of the shape is wrong, then we will have to be able to change and adapt.
Yeah, I will just probably add, I mean, we know saying take offline review becomes super important. If you do an adaptation, you still need to do offline review. So for some reason, there's a shrinking happening, you have to keep track of what's going on offline. But online, instantaneously make a decision where you can treat and then review offline. That's the way I see it.
Yeah, absolutely. In fact, physicians get paid to do weekly review, and I'm sure they'll that is not going to go away. And if you have to, and if the radiographers or radiation therapists are flagging that they have to do that review earlier or later, then that will happen.
Fantastic. Well, again, I want to take this opportunity to thank all of our speakers today. It's been a really good insight into how we as an industry need to drive the future of online adaptive in radiation therapy. And it's been great to talk about some of the benefits that will bring going forward as well. We as a business, Leo Cancer Care, we were really founded to continue to work to drive future improvements in radiation therapy. And as you can tell, we're very excited and very enthusiastic about the area of online adaptive. So we will be at Astro. We will have a number of members of the Leo team at Astro this year in Chicago. We will have our patient positioning system on our booth there. It's booth 1933. And would welcome all of you to come and continue this discussion with us. And we'd be happy to continue talking with you about it. So thank you again, everyone, for joining us. Thank you again to the speakers. Really appreciate your time and look forward to seeing you all in Chicago.
Hey Steve, we have one last quiet question. Most of the participants are still with us. And that's from Dr. Wirtz. So yeah, I 100% agree with you. The CTV is not defined one time. It's really a dynamic. It should be a dynamic volume, and that's really the secret sauce to online adaptive.
Wonderful. Well, thank you again all, and we will see you in Chicago.